Welcome!
Again, everyone, to MCL Charge Capture and Coding channel. Our part 1 and part 2 video lectures for you. If you are watching this video, that would only mean you wanted to learn some more. So today's lecture is about billing and coding for routine food care services on Medicare patients. This is part 3. Full disclosure, the sources of my lectures are CMS website, CPT and ICD-10 CM coding books, and other website resources. Before we proceed, please note that in billing and coding the routine food care services, a foot or toe location modifier is required. If this information is missing in the documentation, please query your provider. Remember that Medicare covers services performed on mycotic nails under the exceptions to the routine foot care exclusion. We already talked about indication and exclusions in our part 2 video lecture, but we will talk more about them here today. If you are reporting a significant separately identified evaluation and management service that is provided on the same day as your routine food care service, append modifier 25 on your EM code. According to CMS LCD reference article A52996, the CPT codes 11305 to 11308 are procedure codes used for shaving of epidermal or dermal lesion. Therefore, it is not appropriate to report any of these codes for the removal of corns and calluses of the feet. Now, removal of these corns and calluses can be reported using CPT codes 11055, 11056, and 11057. Removal of these lesions, corns, and calluses are considered to be routine foot care. Note to billers and coders, the code you select must be supported by the documentation. Again, procedure codes may be subject to National Correct Coding Initiative or NCCI edits or OPS packaging edits. Refer to NCCI and OPS requirement prior to billing Medicare. Toenail agreement procedures for routine foot care services. We use either 11720 or 11721 CPT code depending on the number of toes being debrided. I mentioned in our previous lectures that a Q modifier identifying the class findings must be included on the claim when reporting routine food care services that must meet the Medicare's exceptions to routine food care exclusions. Many physicians will document what Q modifier to use for the condition of their patient. However, if it is not specified, we can choose the applicable modifier according to the class findings they documented. To be in compliance with our coding guidelines, we append this Q modifier to our CPT code, either 11055, 11056, or 11057. We can also append this Q modifier to 11720 and 11721 CPT codes. Q7 modifier indicates that it requires one Class A findings. Look for a non-traumatic amputation of foot or integral skeleton portion thereof in the documentation. Q8 modifier requires two Class B findings from this list. To report the Q9 modifier, documentation must support 1 Class B and 2 Class C findings. See the lists here on this slide. Remember that for our claim on routine food care services to be covered and valid, other than the food or tow location modifier when applicable, we need to make sure we meet the exceptions to Medicare's exclusions. First, remember that there must be evidence of the presence of a systemic condition, either requiring or not requiring the active care of the PCP. Second, indicate the date when the patient was last seen by his primary care physician. Must be a doctor of medicine or a doctor of osteopathic medicine. Third, medical necessity. Your indications must be that which mycotic nails, warts, ulcers, wounds, or infections, for example. These are indications acceptable according to CMS. And lastly, ensure that the class findings and Q modifier are included in your documentation. I would like to mention that at present, peripheral neuropathy or diabetic sensory neuropathy is the most common factor leading to amputation in diabetics. According to Medicare NCD Manual Section 70.2.1, in diabetes, sensory neuropathy is an anatomically diffuse process primarily affecting sensory and autonomic fibers, but take note that distal motor findings may be present in advanced cases. Long nerves are affected first, with symptoms typically beginning over time in the toes and then advancing proximally. This therefore leads to loss of protective sensation. You may find this in your provider's documentation. This makes a person unable to feel minor trauma from mechanical, thermal, or chemical sources. So when foot lesions are present, the reduction in autonomic nerve functions may inhibit wound healing. So this is the reason why patients with this condition need the professional help of a physician to allow for early intervention and avoid more complications with the disease. Medicare covers, as a physician service, the evaluation, examination, treatment, and management of the feet once every 6 months only for individuals with a documented diagnosis of diabetic sensory neuropathy and LOPS. This is as long as patients have not seen a foot care specialist for some other reasons in the interim. There are systemic conditions that require patients to be on active care of their PCP. So if this is the case, the name and NPI of the referring or ordering physician must be reported on the claim. Note also that this must be a doctor of osteopathic medicine or doctor of medicine. Again, reminder, double check if the date of your service provided in your claim will be covered. Review the date when your physician previously provided the same service to the same patient and compare it with the current date of service you are working on in your claim. Because for LCD reference article number A57759, only once in every 60 days will Medicare cover the same service. To ensure payment during the encounter, have the patients sign an ABN form because in case Medicare does not reimburse the service, at least you have made your patients aware that the cost will most likely be charged as out-of-pocket to them as a result. If your claim was submitted without a valid ICD-10-CM diagnosis code or an indication, will be denied and returned to the provider as an incomplete claim under Section 1833E of the Social Security Act. Per LCD reference article of CMS website A57759, the patient's medical record must also contain documentation that fully supports the medical necessity for services included within the LCD. This documentation includes, but is not limited to, relevant medical history, physical examination, and results of pertinent diagnostic tests or procedures. Documentation supporting the medical necessity, such as physical and/or clinical findings consistent with the diagnosis and indicative of severe peripheral involvement, must be maintained in the patient record. In compliance with Medicare's exceptions to routine food care exclusions, the clinical documentation must clearly show that the patient's condition warrants the physician rendering these services, and that failure to provide such professional services would be hazardous to the patients due to their underlying medical condition or conditions. The bill diagnosis should be supported with clinical findings. According to CMS guidelines, failure to properly document the reasoning for the care rendered by the provider may result in denial of the claim. Therefore, there should be documentation of coexisting systemic illness. The physical examination and class findings must be accurately specific with documentation of the location, appearance, characteristics, and symptoms of the toenails or lesions. The procedure note must describe what, how, and where the procedures were performed and correlate these treatments to the lesions documented on the physical examination. The procedure note may reference the physical examination when describing the treatments given during the procedure, such as left great toe, left second toe, or right great toe, right foot, or fourth digit, fifth digit. Thank you so much for watching. I hope you have learned a lot. I enjoyed giving you this lecture. Up next is part 4, wherein we will apply what we learned. We will have problem scenarios, questions, answers, and explanations. See you there.
Thank you!